Hello and good evening, doctors. Welcome to another session of NEET MDS 2024 MCQ discussion. Sorry for being late. It is due to some technical issues. So today we will be mainly focusing on the dental histology and dental anatomy MCQs. Okay, that was asked in the NEET 2024 exam. So before starting the session, let me ask you guys, how was the exam? Dr. Aishwarya, how's the exam? You can put your answer in the chat box. Is it easy or moderate or difficult for you? Tough. Oh, okay. So sorry to hear that, doctor. Anyway, you have now completed the exam. Now let's wait for the results. Let's wait for the results and let's see how it is going. Okay. So don't worry, doctor. So if you look at this dental histology and dental anatomy part, it was comparatively easy. Okay, it was comparatively easy. Most of straightforward questions were there. There were only like 2 image-based questions from the dental anatomy part. Otherwise, comparatively easy questions only. So let's look at it, doctor. So first, we'll be discussing about the MDS NEET MDS 2024 MCQs, and then we will move on to some important previous year questions also. Okay. So first question, identify the age of the patient with the help of OPG given below. Okay, is it 3 to 4 years, 4 to 5 years, 6 to 7 years, or 9 to 10 years? Any guess, Dr. Aishwarya? You remember what answer you had given for this question? B. Okay, 4 to 5 years. Okay. Okay, so it is very evident from this OPG that this OPG shows a mixed dentition of a child. Okay, you can see that all the deciduous teeth were present except the central incisors. Central incisor, you can see the permanent central incisors have erupted into the oral cavity. Okay, and then you can also see that the molars, all the permanent first molars have erupted into the oral cavity. So it's mainly usually the permanent first molars and the permanent lower central incisors, they usually erupt by the age of 6 to 7 years. And you can also see that in this thing, the permanent first molars, they have reached the occlusal plane also. It means that they are not just erupting, but they have reached the occlusal plane also. So instead of the option B, that is 4 to 5 years, I think it's better to choose the option C, that is the 6 to 7 years. Okay, because that is a much more appropriate option. Okay, and you can also see that in the question, the maxillary central incisors have not erupted into the oral cavity. Okay, so it is definitely less than 7 years. So there was a confusion, I think, between the students whether it was 4 to 5 years or 6 to 7 years. But if you look at the molars, you can confirm that the patient is like somewhere between 6 to 7 years because they have erupted and they have reached the occlusal plane also. The incisors, they are like a little bit away from the occlusal plane, but still they are about to reach the occlusal plane. So you can confirm that the patient is around 6 to 7 years of age. So this is the chronological chart that will help you in analyzing the age of the patient. I think you all are very familiar with this. Okay, you can see that the molars, they usually erupt by the age of 6 to 7 years, and also the lower central incisors, they usually erupt by the age of 6 to 7 years. Okay, so you can confirm that it is the option C, 6 to 7 years. Now, identify the structure marked in the image given below. Okay. Any guesses, Dr. Aishwarya? You remember what you had given for this question? C, yes, triangular. Yes, correct, doctor. Because usually, you know, ridges are any kind of linear flat elevation that is present on the teeth. There are many kind of ridges, like facial ridges are there, lingual ridges are there, then the occlusal ridges are there. But for the discussion sake alone, we will be discussing these 4 ridges mainly because these 4 ridges are given in the options. So we'll be mainly focusing on these 4 ridges. First is this marginal ridge. Okay, this marginal ridge is nothing but the ridges that are present around the margins of the tooth. Okay, these are linear rounded border forming the mesial and distal margins of the occlusal surface are called as the marginal ridges. Then we have the oblique ridge. Oblique ridge are mainly present only on the maxillary molars. Okay, so this kind of ridge travels obliquely from the distrobuccal cusp to the mesiopalatal cusp. Okay, so this kind of ridge, the blue thing that is marked here is the oblique ridge. Then we have the triangular ridge. Okay, so this triangular ridge, the one that is given in the question, it extends from the cusp towards the central part of the occlusal surface. Okay, from the cusp tip towards the central part of the occlusal surface. Okay, so this area is marked. So the most appropriate answer is again the triangular ridge. Okay, now if both the triangular ridges have been marked, then we can choose the answer as the transverse ridge, because in the transverse ridge, both the buccal and lingual triangular ridges will be together in form. That is, the buccal and lingual triangular ridges, they together form the transverse ridge. But in the MCQ question that is given, since only this part of the area is marked, then we can choose that it is the triangular ridge. Okay. Now, next question, shedding sequence of primary maxillary teeth. Okay. Any guesses, Dr. Aishwarya? Shedding sequence of primary maxillary teeth. Okay. You remember any options giving, Doctor? Okay. If not, it's okay. Okay. So the actually, yes. Okay, Doctor. That's okay. So actually, the shedding sequence of primary maxillary teeth is option C, A, B, D, E, C. Okay. So we are all familiar with the eruption patterns. Now let's have a look at this shedding pattern. Okay. So if you look at this shedding pattern, usually central incisor, they usually sheds by 6 to 7 years. Then it is followed by the maxillary lateral incisor. Then it is followed by the first molar. Okay, the first molar sheds before the canine in the maxillary teeth. Okay, in the maxillary teeth, the first molar sheds before the canine. Then the second molar and the canines, they have the similar age group of shedding. Okay, they usually shed between 10 to 12 years of age. But usually, if you see in a clinical situation, second molar is shed before the canines. So we have included the shedding pattern of the maxillary teeth as A, B, D, E, and C. Okay. Now, if for the mandibular teeth, how it is again the central incisor, lateral incisor are the first one to shed, and then the cuspids. Okay, the cuspids and the first molars have a similar age group of a shedding pattern. One is between 9 to 12 years, and the another one is between 9 to 11 years. Okay, so 9 to 11 years and 9 to 12 years. But if you look at it clinically, usually canines are shed first, then the first molars, and then lastly the second molars are shed in case of the mandibular teeth. So the shedding sequence of the mandibular teeth is A, B, C, D, E, and in case of the maxillary teeth, it is A, B, D, E, and C. Okay. Now coming to the next question, stratum germinativum includes. Okay. So is it stratum basal or stratum corneum or stratum granulosum together? Or is it stratum granulosum alone, or is it stratum basal and parabasal spinous? Okay, Dr. Aishwarya, you had given it as B. Okay. And Dr. Tasneem, any guesses for this question? Okay. Even if you don't know, it's okay. You can say that you don't know. It's okay. We are all here to learn only. Okay. So actually, the stratum germinativum means the term. Let's look at the term stratum germinativum. Okay. So this that is our usually oral mucosa. Let's take it as keratinized oral mucosa. Okay. This keratinized oral mucosa is made up of so many layers of cells. Okay. There are like 4 layers of cells. In the basement, you have the stratum basal, followed by the stratum spinosa. Then we have the stratum granulosum, and the last layer, the upper layer, is the stratum corneum. Okay. So this germinative layer means it is similar to the germ layers. Okay. So we have three germ layers in our body: endoderm, ectoderm, and mesoderm. Okay. So from these germ layers are only all the organs of our body are forming. Okay. So here also stratum germinativum means there is a layer or there is a particular group of cells where all the keratinocytes are formed. Okay, so the layers which form the keratinocytes, that is the main meaning of this stratum germinative. So for the more keratinocytes to form, what do you think is the important feature necessary for this stratum germinativum for more cells to form? Okay, first thing, it should continuously produce keratinocytes, and second thing, it should have high mitotic figures. Okay, if it has high mitotic figures only, then it has the capability to produce more and more daughter keratinocytes. Okay, so if you look at it, actually stratum basal, okay, stratum basal, they have very high mitotic figures and this thing. And along with the stratum basal, there is another layer that is called the parabasal spinous layer. Okay. Let me show you the picture. Here it is the picture of the histological picture, and here is the diagrammatic picture of this keratinized oral mucosa. You can see that this is the stratum basal, followed by the stratum spinosum, granulosum, and then the cornea. Okay, so these basal layers, they have high mitotic activity and high mitotic figures are present, and along with it, the layer that is present just above the stratum basal. Okay, this layer. Okay, I'm marking it with my pointer. Okay, this layer. Okay, the layer that is present just above the basal layer, that is included in the spinosum layer only, but we can call it as parabasal spinous layer also. Parabasal means just above the basal layer it is present, so it is called as parabasal spinous. Okay, this layer will also have very high amount of mitotic activity and very high number of mitotic figures will be present there, and they also try to continuously produce new and new keratinocytes. So when they ask you what this stratum germinativum means, remember to the germ layers. Germ layers are something which produce all the cells. Okay, so there are some cells in the epithelium here also which has the capability to produce more amount of keratinocytes. Okay, so in the stratum germinativum, it actually includes both stratum basal and the parabasal spinous layer. They together form this stratum germinativum. Moving on to the next question, which among the following is not a cell-to-cell junction? Okay, is not a cell-to-cell junction. Remember that, doctors. Is it desmosomes, hemidesmosomes, tight junction, or adherens junction? Okay, Dr. Aishwarya, Dr. Tasneem, do you remember the answer you have given in the exam? B. Yes, yes, Dr. Aishwarya. Dr. Tasneem, any guesses? Even if it's wrong, it's okay. We are all here to learn only, okay? So it's better to make mistakes now than in the exam hall. So if you have an answer in mind, you can tell it, doctor, okay? Okay. Yes, Dr. Aishwarya, the answer is right. It is actually hemidesmosomes only, okay? So these cell junctions, they can be, they are just consider, you can consider it like a bridge, okay? Like a bridge between two cells, okay? So sometimes people can walk through this bridge, or sometimes the bridge can be blocked also, okay? So this cell, based on that, the cell junctions can be divided into three types. It can be either occluding junctions or tight junctions, where nothing is passed on between the two cells. Then we have something called as the anchoring junctions, where two cells are held together by these anchoring junctions. And then you have the communicating junctions. Okay, two cells will exchange material through these communicating junctions, okay, which are the gap junctions. So if you look at these anchoring junctions, these cells can be held together with the help of two types of filaments. One is actin filament and the other one is the intermediate filament. So in this actin filament also, this actin filament can keep the cells close together, keep two cells close together, or it can keep a cell and the underlying matrix together also. Okay, so that is there will be attachment between the cells, and there will be attachment between the cell and the underlying connective tissue. Okay. So for the if the actin filaments are acting, then those type of cell-to-cell junctions are called as the adherence junction or the cell matrix junction or the focal adhesions they are called. And in case of the intermediate filaments are playing a role, then again it can act between the two cells or it can act between the cell and the underlying matrix. Okay. So such type of intermediate filament mediated cell-to-cell junctions are called as the desmosomes, and the cell-to-matrix junction are called as the hemidesmosomes. Okay. So from this classification itself, you can see that all the other junctions and all the other things that are mentioned in the MCQs in the previous choices are all cell-to-cell attachments except this hemidesmosome. Okay, except this hemidesmosome, which is a cell-to-matrix junction. So this is one of the picture that shows this tight junctions, adherence junction, the desmosomes, gap junctions, and the hemidesmosome. You can see that all these are cell-to-cell attachments. Tight, adherence, desmosomes, and gap junctions are all between the cells junctions. Okay, but this hemidesmosomes alone, you can see that it is between the cell and the underlying extracellular matrix, that is connective tissue. Okay, or the basement membrane. Okay, so this is between the cell and the underlying connective tissue. So this is not a hemidesmosome, is not a cell-to-cell junction. Now moving on to the next question. The ability of the cementum to repair itself to re-establish the root outline is known as. Is it functional repair? Is it physiological repair, anatomical repair, or pathological repair? Okay. Any guesses, Doctor? Dr. Aishwarya, Dr. Namya, Dr. Tasneem? Any guesses? If you remember the answers you have given in the exam, you can put it in the chat box, or even if you don't remember, but now you like at least you can guess the answer now because there's no mark involved here. Okay. So there is nothing called as physiological repair and pathological repair in a cementum. Okay. This physiological repair and pathological repair we can rule out from these options itself. Now the cementum, because of any stress or due to like high occlusive forces, what if some kind of oh yes, doctor. Yes, doctor. Okay. Now if the cementum, because of any increased occlusive forces or because of any trauma, if there is some resorption happening, then it repairs itself with the help of two processes. Okay, one is anatomical repair and the other one is the functional repair. Okay, in the anatomical repair, what happens is that the cementoblast will help forming the cementum again. You can see that this is the resorbed cementum area here. But in the case of anatomical repair, cementoblast help in formation of the cementum again, and it repairs itself, and now it looks like a new cementum itself. Okay, so this is something called as the anatomical repair. The cementoblast will help in forming the cementum, and this cementum will completely fill the defect. Okay, completely fill the defect, and there will be continuity of the root and the periodontal ligament attachment and all. It will be like normal only. Okay, but in case of a functional repair, you can see that in the picture here, you can see that in case of functional repair, what happens is that the defect is here and the cementoblasts are not forming any new cementum. Okay, they are just filled partially by the cementum, and a bay-like defect is formed here. Okay, and a defect is formed here. Now, because of this defect, the periodontal ligament space will be increased. Okay, so to maintain this periodontal ligament space, what the underlying bone does is that the bone will proliferate. Okay, the bone will proliferate and it will form a bony projection here to maintain the PDL width. Okay, so that is called as the functional repair. So in anatomical repair, the cementum will be as new as the old one. Okay, as new as the old one. Whereas in the functional repair, usually there will be bay-like defect and a bony projection will be there. So it is not repaired actually, but for the time being, they are just filling the defect with the help of the bone. Now, next question, most commonly occurring natal tooth is. Okay, which is the most commonly occurring natal tooth? Yes. Any guesses, doctors? Dr. Aishwarya, Dr. Namya, Dr. Tasneem? Yes, Dr. Namya. Yes, Dr. Aishwarya. Okay. Okay, actually, the most commonly occurring natal tooth is mandibular central incisor. Okay. Now, the natal teeth is a teeth which is present at birth. Okay. When the child is born, you can see the small teeth inside the oral cavity. Okay. Such teeth is called as the natal teeth. Now, there is something called as neonatal teeth also. Neonatal teeth means this kind of teeth is present within the first 30 days of birth. Okay. Now, this natal teeth is 3 times more common than the neonatal teeth. Now, various reasons have been suggested for this formation of this natal teeth. Some are suggesting that it is because of the superficial location of the tooth germs. So that is, tooth germs are placed more in the towards the alveolar portion. Okay, that's why this natal teeth are getting formed. And some are suggesting also that it may be because of the increased resorption of the bone. Okay, so 85% of the time it is the mandibular central incisors. Okay, mainly the natal tooth that is formed is the mandibular central incisors. Now, 11% of the time there will be maxillary central incisor that will be forming, and 4% of the time it will be posterior teeth also getting formed. Okay, so the most commonly occurring natal teeth is definitely the mandibular central incisor. Okay, so because of the presence of this natal teeth, what it does is that during breastfeeding and all, when the child is breastfeeding and all, what can happen is that this ventral surface of the tongue, this tongue can impinge in this natal tooth that is present here, and it can form a traumatic ulceration in this ventral surface of the tongue. Okay, this picture here. Okay, it can form a traumatic ulceration in the ventral surface of the tongue. Now, such an ulcer or such a condition is called as the riga fede disease. Okay, remember this riga fede disease. Now, that's all about the 2024 MCQ discussion. Now, let's move on to some of the previous year MCQ discussions. Okay, so coming to the first question, ratio of width to height of the crown of permanent maxillary central incisor is. Okay, these are the options 0.4, 0.8, 0.6, and 1. Okay, this is a question that involves calculation. Okay, so from this year onwards, what they had made modification in the exam pattern is that you cannot take any pen or any calculator or any kind of accessories into the exam hall. Okay, there will be a digital calculator that is present in the screen itself. Okay, from this year they have made this modification. There will be a digital calculator that is present in the screen itself, where you can calculate the if there is any calculation involved like this, then you can calculate it in the digital calculator itself. I think for this exam, for public health dentistry or for general medicine, some 1 or 2 questions, there was calculation involved, and students can mainly use this digital calculator that is present in the screen itself. You cannot take any outside material. Okay. So the answer is actually option B, 0.8. Okay, so let's look at the dimensions of it. Okay, so mainly they have told the width to height ratio of the crown only. Okay, only the crown and not the whole tooth. Okay, so we can just take the cervico-incisor length of the crown, which is the 10.5 mm, and the mesiodistal, the largest mesiodistal diameter of the crown. Okay, we are not using the cervical portion mesiodistal diameter. The largest mesiodistal diameter, that is 8.5, is taken divided by 10.5, which gives the 0.8. So option B, 0.8 is the answer. Okay, now coming to the next question. The area seen between newly formed or repaired cementum and the resorption area is called as. Okay, so the area or the lines that is seen between the repaired cementum and the resorbed cementum. Okay, what is it called? Okay, is it incremental lines of Salter? Is it reversal lines? or is it stria of Retzius, or is it the line of opals? Doctor, okay, line of opals. Okay, Dr. Ramya. Any other guesses, doctors? Dr. Tasneem, Dr. Aishwarya, any guesses for this question? Yes, Doctor. D, the line of opals. Okay. So the one thing that you have to remember here is that the cementum is like very much similar to bone. Okay. In a bone, if there is some resorption happening and there is no deposition happening, the area that is between the newly formed bone and the previous bone, it is called as the, yes, Dr. Aishwarya, it is called as the reversal line. Okay. So cementum, the structure is like very much similar to the bone. Here also, the line that is seen between the repaired cementum and the resorbed area, it is called as the reversal lines. Okay, I'll tell you what this line of Opal-Smith is also. Okay, so here you can see the reversal line. This point here, I'm pointing here. This here, it is the reversal line. Okay, these are the scalloped lines that are seen between the resorbed cementum and the newly formed one. Okay, this may be the resorbed one and this may be the newly formed one. And here you can see this scallop line, which is called as the reversal line. So in case of any trauma or because of high occlusive forces, what happens is that there will be resorption of cementum and there will be apposition of new cementum taking place also. They are trying to repair it, like we had already seen the anatomical repair and all those things. So the cementum will try to repair itself and will try to form new cementum, which will result in a area of deviation between the new and the old one, which is called as the reversal line. Okay, so the incremental lines of cementum, they are called as the incremental lines of Salter, which is given in the option also. This slide is just for discussing the other options. Okay, so the other options that are given are this incremental lines of Salter are given, which is nothing but the cemental incremental lines. Okay, so these kind of mineralized tissues like dentin, enamel, cementum, they are not deposited in a continuously in a continuous phase. Okay, they'll be started depositing in a phase by phase. Okay, like they will the cementoblast will deposit cementum for some time, then they will take a rust phase, then again they will form cementum, then they will take rust, then again they will form cementum, and then again they will take rust. Okay, so because of this rust and active phase, what it does is that in all these tissues, okay, like in all these enamel, dentin, and all these tissues, you can see lot of lines. They are called as the incremental lines. Okay, so for the cementum, the incremental lines are called as the Salter, and next is this enamel. For enamel, these incremental lines are called as the stria of Retzius, or the lines of Retzius, you can call it. So in enamel, it is the stria of Retzius. Okay, then let's see what this hyaline layer of Hopewell-Smith is. Okay, this line of or area of Hopewell-Smith is also called as intermediate cementum. Okay, this kind of cementum is usually it is the cementum that is separated from the dentin. Okay, usually in the root area, the cementum will be attached very much to the dentin. But in case of, in some situation, what happens is that the cementum can get separated from the dentin, and this will form a hyalinized area between the cementum and the dentin. Okay, so this hyalinized area that is present between the cementum and the dentin is called as the intermediate cementum, or it is also called as the hyaline layer of Hopewell-Smith. Okay, it is much structureless in nature, and you cannot call it as a cementum nor dentin. Okay, it is like it doesn't show the characteristics of cementum, and it doesn't show the characteristics of dentin. So it is like a separate layer that is there. And usually such kind of this hyaline layer of Hopewell-Smith is usually seen in the apical portion of the teeth. Okay, so I hope I had made myself clear. Now moving on to the next question. Which of the following is not a succedaneous? Okay, it is not a succedaneous. Succedaneous teeth means these kind of teeth, they do not have predecessors. Okay, so usually primary teeth will be there, then the primary teeth will shed, and in that place, a permanent teeth will come. But in this type of teeth, there will not be a predecessor that is present. Okay. So what kind of teeth does not have a predecessor? Any guesses, doctors? Dr. Aishwarya, Dr. Namya, Dr. Tasneem? Any guesses? Okay. Okay. Okay, doctor, I'll tell you. I'll explain to you. Actually, the option is A, 1/6. Okay. So this permanent teeth, okay, this permanent teeth can be classified. Okay, basics of dental anatomy. This permanent teeth can be basically classified into two types. Okay, there is succedaneous teeth and the non-succedaneous teeth. Succedaneous teeth means all these teeth. Okay, the bluish colored teeth that are present here are the succedaneous teeth. Okay, that is they have a predecessor. That is they already have some kind of a deciduous teeth that is present in its place. Okay, then this deciduous teeth will shed, and these blue colored teeth will come into position here. Okay, such teeth are called as the succedaneous teeth. Okay, main example is definitely the central and lateral incisors, canines, first and second premolars are all succedaneous teeth. Okay, then okay, doctor. Then you have something called as the non-succedaneous teeth. Non-succedaneous teeth means there will be no deciduous teeth present in its place. It will come on its own. It does not have to wait for the deciduous teeth to shed or anything like that. It does not have to wait for it. Okay. So only first, second, and third molars are all non-succedaneous. Okay. So the questions can be a little bit confusing sometimes. So please read through the questions thoroughly and then read through the options thoroughly also, and then try answering the questions. Okay, doctor. Now, okay. Okay. The concentric dark lines that are present in the ground section of enamel are okay. The concentric dark lines that are present in the ground section of enamel are called. What is it called? Is it called the incremental lines of Retzius? Is it the Hunter-Schriger bands, or is it the imbrication lines, or the neonatal lines? Any guesses, doctors? Dr. Namya, Dr. Aishwarya, Dr. Tasneem? Okay, that's okay. I'll tell you. I'll explain it to you. It is actually the incremental lines of Retzius. So when you cut a tree in cross section, you can see that many concentric lines like this. Okay, this is the cut section of a tree. Okay, similar to this, when you cut a tooth in the cross section, you can see in the enamel part lot of incremental lines like this. Okay, this lot of concentric incremental dark lines will be seen. They'll be extending from this dentino-enamel junction to the outer surface. Okay, towards the mainly towards the this portion to the cusp tip and all those portions, you can see that it will be forming a concentric circle like this, and towards the outer surface, and if you look at the cervical region and all, it will be mostly in the 90 degrees like this. Okay, you can see the oblique part of oblique direction of this incremental lines of Retzius in the cervical portion. Okay, so this is the arrangement of the incremental lines of the stria of Retzius, and it usually represent the periods of rust. So as I had already mentioned, it will not be deposited in a continuous phase. All these mineralized structures will be deposited by phase. Okay, so these lines, they represent the periods of phase, periods of rust, or you can call it as the period of quiescence. Okay, so the enamel that is present between this line is the actual they represent the active period of the ameloblast. Okay, and these lines represent the rusting period or the quiescent period of the ameloblast. So we will be discussing the other options also. There is an option called Hunter-Schriger bands that is present in it. So this Hunter-Schriger bands is nothing but it is just the zebra lines of the enamel. Okay, you can call it as the zebra lines of the enamel. Okay, for easily remembering it. Okay, what it is mainly dark and light bands in the longitudinal section of the enamel. Okay, so and then if you view this ground section in a normal microscope through the normal light, you will not be able to see this Hunter-Schreger bands. Okay, when you view it through the oblique light only, this Hunter-Schreger bands will be visible and they'll be more near the dentino-enamel junction. Okay, towards the periphery, they'll be like less pronounced. Okay, and some of the people have suggested that this Hunter-Schreger bands is because of some decreased in the mineral content or because of the density of the enamel. Because of that, this is forming. But now it is mainly established that this Hunter-Schreger bands is mainly because it is just an optical phenomenon. Okay, because of the light variations. Okay, since all these incremental lines are going in different directions, when we change the light to a different position, only this Hunter-Schreger bands is. Okay, it is just an optical phenomenon, nothing related to the mineralization or the other things. Okay. Then next is the neonatal line. Okay, neonatal line that is present in this enamel is it is an accentuated line. Okay, like a prominent line that is separating the enamel formed before and after. Okay, so before birth itself, there will be the enamel formation that is taking place in some of the teeth. So this line separates the enamel that is formed before birth from the after birth. Okay, so it is most commonly seen in the deciduous teeth and the first permanent molars. Okay. Mainly, Dr. Ramya, it is not to because of the lines itself are positioned in a different pattern. Okay, if you look at the incremental lines, they will be like passing through in a concentric circles very closely together also only. Okay, so in the if you look at the cervical region and all, they will be passing very obliquely, whereas in the other portions they will be like very much closely related and very much in the concentric areas. So everyone thought that it may be due to some changes in the composition and all, but they had done research on that also. And now they finalized that there is no difference in the composition or anything like the density or something. It is mainly an optical phenomenon only because of this line directions. Okay, because of the changes in directions of this line only. Okay. I hope it's clear for you, Dr. Namya. Okay, okay. So we are discussing about the neonatal line. Okay, neonatal line is something that separates the prenatal enamel from the postnatal enamel. Okay, that in the during the prenatal time, there will be like continuous supply of the minerals and the nutrition to the area. So that will be formed in a particular order. But after the birth, sometimes fluctuations can happen. That will result in the formation of a different pattern of enamel. So between these two, there is something called as the accentuated line, which is called as the neonatal line is present. Now, the last one is the imbrication lines. Okay, this imbrication lines is also called as the perikymata. Okay, so this imbrication lines of pickerel, they are called as the imbrications lines of pickerel, and they are also called as the perikymata. Okay, so if you look at this, mainly it is mainly prominently seen in the canine region. If you feel the buccal surface of the canine, you can see some parallel wavy like grooves that are present in near the cervical region. Okay, they are called as the imbrication lines of pickerel or the perikymata. Okay, so what it is that it is mainly considered as an external manifestation of the stria of Retzius. Okay, so this concentric lines are the stria of Retzius. Now this perikymata is considered as the external manifestation of the stria of Retzius. Okay, that is this portion. Okay, so they are like parallel to each other in wavy pattern are seen. Okay, now an easy way to demonstrate this perikymata is by if you rub a few amount of graphite on the teeth, then you'll be able to visualize this perikymata very easily. Okay, so these are the other options that are given in this question. Now, ameloblast originate from, is it ectoderm or ectomesenchyme or endoderm or mesoderm? Okay, where does this ameloblast come from? Any guesses, doctors? Dr. Aishwarya, Dr. Namya, Dr. Sri, Dr. Tasni. Okay, okay, Dr. Aishwarya. Any guesses, doctors? Ectoderm. Yes, doctors. All structures, okay, all the dentin, pulp, cementum, bone, and all others are derived from the ectomesenchyme, okay, except ameloblast, which is derived from ectoderm, okay, ectoderm only. So mainly our germ layers have divided into two, ectoderm, mesoderm, and endoderm. And in the case of this tooth formation, there is something called as the ectomesenchyme, okay. This ectomesenchyme is nothing but there will be connective tissue, embryonic connective tissue. Okay, not the normal connective tissue, mature connective tissue. There will be embryonic connective tissue. To this embryonic connective tissue, lot of cranial neural crust cells are coming. Okay, this cranial neural crust cells are some specialized cells that are coming and getting embedded in this embryonic connective tissue. So together, this embryonic connective tissue along with this neural crust cells, they are called as the ectomesenchyme. Okay, now this ectomesenchyme is responsible for the formation of the dentin, cementum, pulp, and all the other structures of the teeth, except enamel alone is derived from the ectoderm, ameloblast, which are derived from the ectoderm. Okay, now coming to the next question. Excretory duct of submandibular gland is known as duct of, is it Rabinus, Wharton, Stanson, or Blandin and Nunn? Okay, any guesses, doctors? Is it option A, B, C, or D? Duct of submandibular gland. Okay, so there are, we have three major salivary glands that are present. One is the parotid gland, then submandibular gland, and the sublingual gland. Okay, submandibular, the parotid gland, it mainly opens opposite the buccal surface of the second molar that is present here, and it is called as the Stenson's duct. Okay, it is called as the Stenson's duct. And submandibular gland, the duct of the submandibular gland is called as the Wharton's duct. Okay, it is called as the Wharton's duct. The correct option for this question is Wharton's duct. Okay, so this Wharton's duct, it opens near a small papilla. Okay, this small area of opening of this Wharton duct is called as the Caruncula sublingualis. Okay, it is called as the Caruncula sublingualis, and it is this small opening is present at the side of the lingual frenum on the floor of the mouth. Okay, at the floor of the mouth on the side of the lingual frenum, you will be seeing a small papilla with an opening which is called as the caruncula sublingualis. Okay, now the duct of the sublingual gland, there are two ducts for the sublingual gland. The major duct is the Bartholin's duct only. It opens near the submandibular duct in the near this caruncula sublingualis itself, and another minor duct of this sublingual gland is the ducts of Rabinus. Okay, it's not just one duct, it is like a multiple ducts together. Okay, they are called as the ducts of Rabinus. Okay, and they just open in the sublingual fold altogether. Okay, so that is the three major salivary glands and their ducts. Okay, parotid gland, we have the Stenson's duct. Submandibular gland, we have the Wharton's duct. Sublingual gland, there are two types of duct. One is Bartholin's duct and another one is the ducts of Rabinus. Okay, now there is another option that is given, option D, that is the Blandin and. Okay, this Blandin and Dunn is not a duct itself, it is a minor salivary gland. Okay, so if you look at, so these parotid, submandibular, sublingual are all the major salivary glands. Now, if you look at the minor salivary glands, there are two main groups of minor salivary glands that are present in the oral cavity. One is the von Ebner's gland and another one is this Blandin and. Okay, this von Ebner's gland is nothing but it is a purely serous gland. Okay, in the major salivary gland, the purely serous gland is mainly the parotid gland. Okay, so like that, in the minor salivary gland, the purely serous gland is von Ebner's gland that is present in the posterior part of the lingual glands. Okay, and it usually opens into the circumvallate papillae. Okay, in the middle third of our tongue, we have the circumvallate papillae. Okay, so to the circumvallate papillae and to the foliate papillae only, these worn epidermis glands are opening. Okay, and then we have the minor salivary gland, Blandin and Nun. Okay, this Blandin and Nun is present at the apex of the tongue. Okay, they are present at the apex of the tongue. Okay, so one is present at the posterior third or middle third. You can tell that posterior third, and the other one is present at the apex of the tongue, and this is mucus gland. Okay, this Blandin and Nun is mucus gland and it opens to the ventral surface of the tongue near the lingual tree. Okay, it opens to the underlying ventral surface of the tongue. So I think you are all familiar with this terminologies here. Remember all these terminologies, okay, doctors, because it can be repeated again. Okay. Now, dentin that is freshly laid over the pulp is called. Is it pre-dentin, mantle dentin, secondary dentin, or circumpulpal dentin? Okay. These questions are mainly included to make you familiarize with you to the terms. Okay. There are so many terms like this in the dental histology part, like pre-dentin, primary dentin, secondary dentin, tertiary dentin. All those things are there. So to make you familiarize with these terms only, these questions are mainly included. Okay. Any guesses, doctors? Okay, okay, doctor. And that's okay. This is actually called as pre-dentin. Okay. The dentin that is freshly laid over the pulp. Okay. In this picture, in this histological picture, you can see that these are the odontoblast and this is the dentin layer. And in between this odontoblast and dentin layer, you can see a less mineralized area. Okay. That is called as the pre-dentin layer. Okay. Is a newly laid down dentin that is present over the pulp is less mineralized when compared to the normally formed dentin. That is why it is pale stain. Okay, it is much white color in this because of this thing only. It is less mineralized. Pale stain is seen because of the less mineralized structure of this pre-dentin. Okay, this usually 6 to 10 micrometer in diameter, very less only. So dentin, it can be broadly classified into primary, secondary, or tertiary. Okay, the dentin that is formed before root completion is called as the primary dentin. The dentin that is formed after root completion is called as the secondary dentin. Okay, then there is something called as tertiary dentin also, which is the dentin that is formed in response to a stimuli because of some trauma or because of something. There will be like excess formation of dentin in that region, which is called as the tertiary dentin. Okay, tertiary dentin alone is the pathological process, whereas primary and secondary are both the physiological process only. Okay, so this primary dentin is again divided into two types. It is divided into mantle dentin and the circumpulpal dentin. Okay. So in this picture, you can see that this light yellowish color thing that is seen here. I don't know if you are able to see, but you in the crown of this teeth, you will be able to see a light yellowish color structure that is called as the mantle dentin that is deposited, and all the other dentin is it is called as the circumpulpal dentin. Okay. Now coming to our next question. In a two-digit tooth numbering system, 3 refers. Okay. In a two-digit numbering system, 3. We usually use this numbering system only. 3 means is it permanent maxillary left canine or permanent mandibular left canine or permanent maxillary right canine or permanent mandibular right canine. We usually use this numbering system in our clinic and all. It's permanent mandibular. Yes, Dr. Namya. Answer is right. The permanent mandibular left canine only. Yes, Dr. Aishwarya, you both are right. Okay, so the tooth numbering system, again, going back to basics, it is mainly of 3 types. You have the universal system, Sigmondi or Palmer notation system, and the two-digit system or the FDI system. Okay, so here it is the two-digit system or the FDI system is given here. So for the deciduous teeth, it starts from the 5, 6, 7, 8, and all the other numbers are given. And in case of the permanent teeth, it is 1, 2, 3, 4, and the other teeth are numbered accordingly. So in this 3, 3, it usually comes to lower left kidney. Okay. Now the universal system. Let's look at this universal system. In the universal system, it is the continuous numbering. In case of the deciduous teeth, they are using the alphabets from A to K is used for each tooth. And in case of the permanent teeth, 1 to 32 numbers are used for all the tooth. And in case of the sigmoid or Palmer notation system, it is mainly the angular system, okay, where you will denote it with the help of an angle. If it is like upper right or upper left, you will denote it with the angular system. Okay, angular system is mainly used for the sigmoid or the Palmer notation system. Now coming to the next question, keratinocyte cell migration from basal layer to the surface layer is called as. Okay, what is the process name for the migration of the keratinocyte cell from the basal layer to the surface layer? Is it called as maturation, or is it called as proliferation? Is it migration or differentiation? Okay, any guesses, doctors? Okay, that's okay. I will explain it to you. It is actually called as maturation. Okay, so like I told previously, there are 4 layers in a keratinized epithelium. You will have the basal, cornea, granulosum, spinosum, granulosum, and the cornea. Okay. So what happens is that in this stratum basal layer, they have 2 types of cell population. Okay. In this stratum basal layer, they have 2 types of cell population. Okay. One is called as the progenitor population, and the other one is called as the maturity population. Okay, so we know that this stratum basal comes under the germinativum layer. That is, it has the ability to produce more and more keratinocytes. Okay, so in this stratum basal, 2 types of cells are there. One is progenitor population, and the other one is the maturity population. In the progenitor population also, a few cells are stem cells. Okay, stem cells have the ability to continuously replicate and form new cells. Okay, that are called as the stem cells. Okay, then the other one is the amplifying cells. So in the stem cells, what they do is they will produce more and more basal cells. Okay, and those basal cells will stay in the basement membrane. Okay, such type of cells are produced by these stem cells. And in case of the other population, that is the amplifying cells. Amplifying cells, what they will do is that they are also basal cells, but they will get converted into the maturity population. Okay, these amplifying cells will go into the maturity population. That is, these amplifying cells from this basement membrane, they will start moving. Okay, they will jump to the next level. Okay, they will jump to the spinosum there. And then they will be in the spinous layer for some time. Then they will again jump to the granulosum there. Okay, then they will be the granulosum layer for some time, and then these cells will again jump to the corneal layer, and finally they will be shed off. Okay, so this is the basic characteristic of an epithelium. Okay, a lot of cells will be forming in the basement membrane, and these cells, some cells, okay, not all cells will move to the upper units. Only some cells will move to the upper units, and these cells, they will pass through each and every layer. Okay, they will go from this basal to spinosum to granulosum to cornea. Okay, now so while moving from this one layer to the another layer, their size and shape changes. Okay, usually by reaching the corneal layer, they'll be usually flat and devoid of any cell organs. Okay, and finally they will be shed off. Okay, so this process of movement of the cells from the basal layer to the surface layer or the corneal layer, it is called as maturation. Okay, so this process is called maturation, and the time taken for maturation is called as the turnover rate. Okay, remember these terms. The process of migration or the movement of these cells from the basal layer to the in the epithelium only. Okay, I'm talking only about the epithelium. The epithelium from the basal layer to the corneal layer, it is called as the maturation, and the time taken for this maturation to happen, it is called as the turnover rate. Okay, so the average turnover rate for the oral mucosa is usually 27 days. Okay, nearly 1 month. Okay, that is the average turnover rate for the oral mucosa. Okay, and this turnover rate is very much increased in the oral mucosa when compared to the skin tissue. Okay, the turnover rate is very high in the oral mucosa when compared to the skin tissue. Okay, so that's why when some trauma or when some injury happens in the skin, it is taking more time to heal, whereas in the oral mucosa, it heals very fast. Okay, because of this increased turnover rate only, faster healing and less scarring is happening in the oral mucosa, whereas it is very much less in case of the skin tissue. Okay, so this turnover rate is something very important in cancers. Okay, so the turnover rate will be very much increased in all the carcinomas, like in squamous cell carcinoma and all. The cells will be like continuously dividing, continuously forming, and they will be going to the corneal layer also. Okay, so the turnover rate will be very much increased in case of the epithelial carcinomas. Okay, now there is one more disease which is not a malignancy, which has high turnover rate. Okay, can you guess, doctors, which is that disease? This is a skin disease. Okay, this is a skin disease, not a malignancy, but it has very high turnover rate, more than a malignancy. Any guesses, doctors? Other doctors? Dr. Aishwarya, Dr. Tasneem, Dr. Sri. Any guesses? Okay, actually, it is psoriasis. Okay. Yes, good. Okay. Actually, it is the psoriasis. Psoriasis is the skin disease which has more turnover rate than a malignancy. Okay. Because the skin will be continuously shedding and will be the pruritus will also be very high in case of the psoriasis. Okay. So please remember this maturation and turnover rates. Okay. Now, moving on to the next question. Identify the tooth based on the occlusal surface image given here. Okay. This is the occlusal surface of a tooth. Please identify that. Is it right mandibular first molar, left mandibular second molar, left mandibular first molar, or right mandibular second? Yes, Dr. Namya. Yes, Dr. Aishwarya. Both are right. Okay, yes, it is the right permanent first molar. Very evident from the 5 cusps itself. Okay, these 5 cusps are mainly present in the mandibular first molar only. Okay, and the shortest cusp, okay, the smallest cusp that is present is the distal cusp. Since the distal cusp is present towards the right side, we can say that it is the right permanent first molar. So let's have a discussion about this anatomy of this right permanent first molar. Okay, so the only first molar and second molar are the choices that are given here. So you can see that in the first molar, there will be 5 cusps and the distal cusp will be the smallest one. In case of the second molar, it only has 4 cusps only. Okay, this is the picture of the first molar and this is the picture of the second molar. Okay, only 4 cusp in case of the second molar and 5 cusp in case of the first molar. And I think you are all familiar with the ridges, cusps and the fossas and all. So let's mainly discuss the differences. Okay, how will you differentiate between this first and second molar? Let's mainly look at the differences between the first and second. Okay, so if you look at the occlusal aspect of this first molar, it will be usually pentagonal in shape. Okay, this is the pentagonal shape of the mandibular first molar, whereas it is usually rectangular in shape in case of the second molar. Okay, this is usually rectangular in case of the second molar and pentagonal in shape in case of the first molar. The cuspal pattern is in the shape of Y. Okay, since 3 cusps are there, it will be usually in the pattern of Y in case of the first molar, and in case of the second molar, it will be like a plus sign. Okay, like in a plus sign, the second molar will be there. 5 cusps present in the first molar and only 4 in the second molar. And if you look at the cusp, the distal cusp is the extra cusp that is present here, along with the 2 buccal and the lingual cusp. And in case of the second molar, distal cusp is absent. very good. The roots are very much divergent in case of a first molar, whereas it is very much closer in case of a second molar. And the mesial root, it is usually wide buccolingually in case of the first molar, and it is slightly narrower in case of the second. Okay, so I hope you understood the differences between the first and second molars. Now, moving on to the next question. What kind of secretion is shown in the image given below? Okay, is it apocrine, paracrine, merocrine, or holocrine secretion? Okay, somewhat related to physiology, but it is there in the dental histology part also. Okay, so if you look at this picture, you can see that inside these cells, there are some vesicular areas. Okay, so these vesicles will be present here, and this vesicle will get attached to this membrane here, and then it will release the contents into the outside. Okay, so this is a form of secretion of exocrine gland. Okay, so can anyone tell me what are the three forms of exocrine secretion? They're given in the options itself. This actually apocrine, merocrine, and holocrine. Okay, they are the three types of exocrine gland secretions. Now, out of these three, apocrine, I will rule out this B for you. So, for this apocrine, merocrine, holocrine, what do you think it is, doctors? Dr. Aishwarya, Dr. Sri, Dr. Tasneem, what do you think it is? Any guesses, doctor? Okay, okay. Okay, let's see, doctors. It's actually merocrine. Okay, let me tell you what. Okay, so this exocrine gland secretions, they are of mainly three types. One is merocrine, then there is apocrine, and then there is holocrine. Okay, so the one merocrine is given here. Okay, in this merocrine gland is secretion, or this merocrine glands, they are also called as eccrine glands. And what happens in this is that there will be secretory vesicles like this. Small vesicles will be there, and it will be getting attached to the cell membrane, and they will be releasing the content into the outside, into the duct. Okay, such type of secretions are called as the merocrine type of secretions, and it is most commonly seen in the sweat glands, salivary glands, tear glands, and in the goblet cells and all. This type of secretion is most commonly seen. Okay, now coming to the next thing, that is the apocrine. Okay, in case of this is the example of the apocrine gland secretion. You can see that the apical portion of the cell, okay, this apical portion of the cell is getting pinched off, and the whole cell along with the contents is released into the duct. Okay, such kind of secretion is called as the apocrine type of secretion. So always remember, apocrine means apical portion of the cell is pinched off. Okay, apical portion of the cell is pinched off along with the secretion to the duct, and into the duct it is. Okay, the main example of this apocrine type of secretion is mammary glands. Okay, remember it is the mammary glands. Okay, so the next one is the holocrine. Holocrine means the whole cell itself is destroyed in the process of secretion. Okay, that is the holocrine. Okay, so remember, holocrine means whole cell is destroyed. Apocrine means only the apical part of the cell is destroyed, and in merocrine, vesicles will be there. Okay, so this kind of holocrine secretion is usually seen in case of the sebaceous glands. Okay, sebaceous glands in skin and all. Usually, the entire cell will break down and it will release its contents into the duct. And the other option that is given here, that is the paracrine. Okay, option B, paracrine was also there. So what do you mean by paracrine? Paracrine is not involved in the exocrine type of secretion. Okay, so mainly the secretions are mainly of two types. You have three types actually. You have the endocrine, which passes through the blood vessels. Then you have the exocrine, which passes through the ducts. And then you have something called as the paracrine. So paracrine, what it does is that the cell will release its content into the local environment. Okay, that is, it will release its content into the local environment, And these secretory granules will act on the cells that are present in the local environment. Okay, only the neighbors will get benefited from this paracrine signaling. Okay, long distance it will not travel. Only the neighbors will get benefited from this paracrine type of signaling. Okay, so that are the three types of signaling that are present. Okay. Now, recently discovered gene that is involved in odontoblastic differentiation. This is a little bit hard question. Okay. A recently discovered gene is actually, it is option D, MAP1B gene. Okay. Remember the gene names, okay? Because sometimes in oral pathology, in histology and all, not usually, but sometimes if they want to make the question paper very tough, then they can ask this gene also. Okay. So the gene that is mainly involved in this odontoblastic differentiation, which is discovered recently, is this MAP1B gene. Okay. So let's see what this MAP1B gene is. It is nothing which is called as the, it is also called as the microtubule associated protein. Okay. It is called as the microtubule associated protein 1B gene. And it is actually a neuronal marker. Okay. That is, it is mainly present in the nervous system. Okay. It is mainly expressed in the central and the peripheral nervous system during the neurogenesis and the axonal formation and all. Then there only usually we have seen this kind of gene. Okay, but when they check for the this type of gene in the odontoblast from by taking from a tooth, they took a odontoblast and then they checked for this gene. They were amazed to find that this gene was present also in the odontoblast in the teeth. Okay, it may be because of the neuronal crystal migration and all. That's why some part of the neuronal markers will be present there in the odontoblast and all. So it is also present in the odontoblast during the odontogenesis process. Okay, during the formation process, during the dentinogenesis process, this gene, this marker was particularly expressed, and it is also seen in the carious lesion which are undergoing reparative process. Okay, like when the tertiary dentin or the pathological dentin is formed, then also they were able to see this MAP1B gene. Okay, so just understand the name and understand what it is, what like whether it is a neuronal marker and where it is expressed. Okay, you don't have to go deep into it. Okay, so I hope that's too much dental anatomy and histology for today. So thank you for attending the classes, doctors. We will be conducting other live sessions also for the other subjects also. Okay, so please attend that also. Thank you for attending. Thank you so much.